So I'm the Lymphoedema Advanced Nurse Practitioner at the Royal Stoke University Hospital. I'm also a proud trustee of the British Lymphology Society. And I was reading with interest the best practice bundle from the National Wound Care Strategy the other day. And if it's not something that you've yet come across, I would drive you to the National Wound Care Strategy website to have a look at the bundle. The aim of it is to look at improving healing rates, reducing recurrence, and reducing the burden of lower limb wounds. And what really interested me is, for the first time in a long time, it started to look at defining the length of time that's required for the interventions that we do, and actually hearing about the leg club model and methodology and the time that's spent with patients. I think yesterday's discussions in our workshop showed that we don't have the time that we want, and we don't have the time to focus on the things that are perhaps more important than the actual doing, which we certainly unpicked in our group around skill mix. I also think that reading the bundle, it's really interesting to think about workforce. And as we said, skill mix in our discussions yesterday is key to taking things forward. And if we look at the leg club methodology in its essence, the volunteer, the patient, the carer and the family is a massive part of that skill mix, whereas we think of just paid healthcare professionals within an exact group. So please do start to think differently about that. You heard from two of my national colleagues yesterday, Mel and Karen, both after dinner, and as part of their drive really with their national work in Wales. And what's so interesting is, for those of us that are passionate about lymphedema and chronic edema, we cannot separate it from wound care. So we can't have wound care in one group and then the management of swelling and lymphedema in another. They have to be unified and they have to be together. And our work as the British Lymphology Society, alongside the Leg Club as coalition partners of the Legs Matter campaign, means that we've been able to unite and drive forward this agenda. So from Christine Moffat's work, we know that a very significant proportion of patients have both conditions, but actually that's only where there's probably quite significant edema that actually it's picked up, because many of those patients will have very mild edematous changes that aren't picked up. We know that that swelling will inhibit and impair healing. And we know that if patients develop a wound when they're already well controlled with their edema, it's very likely to be minimal and probably heal relatively quickly with simple technologies. We know that we use the terms lymphedema and chronic edema interchangeably, and that causes a lot of confusion amongst the healthcare professionals involved in wound management. So what does that do for our patients and their carers? Have I got lymphedema or haven't I? Will you talk about oedema or chronic edema? We can feel really confident they're one and the same thing. So we need to break down those barriers as healthcare practitioners so that we can advise our patients and carers. And we know that there are specific risks associated with chronic swelling, like cellulitis, and we have to be trained in identifying cellulitis as opposed to lower limb inflammation. So if the symptoms are bilateral, it's very unlikely to be a cellulitis. We need to be much more proactive in managing these conditions and getting it right first time. So I'd just like to draw your attention to a checklist that we've drawn up in our local area that we hope will be rolled out nationally. This is something that we're hoping that primary care practitioners, primarily GPs, will take on board. And in our area, we have about an 80% sign up now within the local primary care areas. So looking at when patients have swelling, what can be done prior to them achieving any hands-on care for that swelling to see if we can improve things. So first of all, we're looking for escalating any red flags. We've tried to stay in line with the National Wound Care Strategy's recommendations within the lower limb pathway so that we keep the same terminology, the same training, so that hopefully we get the same message there. And if any of those red flags are identified, that we refer on for urgent care as appropriate or refer on to other specialists. The second thing is what to ask the individual. So do they have photographs of when the swelling started? Because I guarantee you it's very hard to pinpoint when that first started. So what people say is, oh, I've had it for ages, or I've had it for a good while. But actually we're trying to find out when. Is it extremely long standing? And in most cases it tends to be. So we're trying to extrapolate that. Is there a risk of something acute? So if the swelling is unilateral, it raises some flags about whether there could be an underlying pathology that we want to exclude, be that pelvic or be that deep vein thrombosis. Do they have a history of cancer? Many patients had treatment for prostate or bowel cancer many, many years ago. Could this possibly be related? Could it be related to the surgery that they had, or could there possibly be a recurrence? So really important to exclude
Any history and any recurrence. And then if the swelling is bilateral, we should be moving forward to exclude any other causes. So we then would think about some of the medications the patients may be taking. So calcium channel blockers are the main responsibility. We find many patients on amlodipine. And actually what we find in primary care is often steps down to lercanidipine. Oh, well, that's much better. But we still encounter the same problems. So looking at those medications, then looking at whether a patient has any varicose veins or any venous insufficiency, which would benefit from referral to the vascular team. And from an immobility perspective, what can we do to improve that mobility? Patients should have had home assessments with OMT or physiotherapy to move forward. We then need to think about what investigations could be considered
locally to help aid our cause or investigation into the cause of swelling. Every patient who has any level of reduced mobility, bilateral lower limb swelling and any breathlessness should undergo an NT-proBNP test to exclude heart failure as a cause of their edema. It's a very quick and simple diagnostic test to ensure that we're treating patients appropriately. We should be looking at full blood count. We know that anemia can result in swelling, and we should also be looking at following any recommendations from the heart failure document that Wounds UK have produced, which aids our management of swelling in patients who do have an element of stable and controlled heart failure. So if you haven't read that document, do have a look, because previously many patients have been told they can't have any compression if they have a diagnosis of heart failure, and we know that that's not correct unless it's acute. We should be looking to
exclude any abdominal mass and any renal conditions that may be contributing to their swelling. Same for any thyroid. Many patients are on thyroxine and have an annual test, but there's very little change that occurs for them for many years, and also any hematological conditions. It's really important that our primary care colleagues work alongside us with doing all of this whilst the patient is moving forward with their wound management or edema management. This way we get a complete and comprehensive picture of what is causing the edema, excluding anything that may be acute, and then allowing us to promote the very best care and get it right first time. We know that there is one specific condition with thickened nails that look very yellow, both on the toenails and on the fingernails, that's associated with bronchiectasis. It's yellow nail syndrome, so patients have very significant lower limb edema, and it's always been considered to be quite rare. But we do encounter a significant number of patients with bronchiectasis under respiratory
medicine, and actually it's rarely identified. So we've had patients who've had the condition for many years. So there are lots and lots of medical conditions which can underpin not just acute edema, but chronic edema. And we just want to get all of us starting to think about investigating that cause before we just assume it's a little bit of dependency or mobility related ankle and foot swelling. It can be a lot more complex. So the aim of the document is for you guys to cherry pick out of it what might be useful in your areas, change it and use it as you will. Everything will be made available to the Leg Club, so if you get in touch you can definitely have copies of anything. But we really need to stop identifying wound care and chronic edema care or lymphedema care as separate entities. We really have to embrace that patients they live with these concurrent conditions, and it's no good treating one without the other. And the good news is the treatment is pretty much the same. So we don't need to learn a whole different set of skills in the main part. We can utilise the skills that we've got and try and adapt them to meet our patients' needs. So that's my little plea for chronic edema over.